Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to Back in Action. Josh here with Coach Dusty Holden. Dusty, welcome to the show.
Hey, man. Thanks for having me.
Thanks for being here. And also, Dr. Lavelle, thank you for being here.
Good to be back. Let's get at it.
Yeah, last time we talked about fear. And mainly it was fear of movement, but that's not really it's not the kinesiophobia, if you want to get a real technical word behind it, that we're really talking about. It's really the movement that we think creates pain. So it's really fear of pain. And I wanted to talk today about pain, what is pain, and all the different versions that we may feel. And I wanted to start out with a hypothetical just to put you on the spot.
Love it.
So I come to you and I've been in pain, let's say 6 months, non-specific lower back pain. You do all the images, or you have all of the images, you have an MRI, you have x-ray, and for all intents and purposes, there's nothing going on. Am I making it up?
Good question. And that's probably my average patient is what you just described. And obviously there's always going to be something going on in MRI because we all get older, things fall apart, things change, but nothing out of the ordinary is what I assume you're talking about.
Yes.
But they're in pain. So pain, we can kind of break it down a little bit, but it's easier to think about pain in the low back. You can't really see the generators. Is there inflammation? Is there something causing it? So let's say you have a finger cut. I think I used that last episode too. But when you cut your finger, that can cause inflammation, cytokines, that the nociceptors, which are the receptors in your finger, that then start that process of pain. But if you have lidocaine on your finger and you cut it, you're not going to ever know you have pain. So pain starts somewhere, sometimes with an injury, but sometimes not. What processes that pain is what's in our brain. And this is where it gets hard with patients, especially in chronic pain, but even acute pain too. You'll never have pain if it doesn't go through your brain. So patients say, am I just making this up? I've had this so long, you say my imaging's fine. I don't have any, noticeable change in my back, no cuts, no falls, but I'm in pain. That's because your pain is processed in your brain. So it has to get there somehow, and then the whole process starts. So if you cut your finger, you have inflammation, cytokines develop, and it goes up the pathways. So there's different nerves that then bring it up. There are alpha nerves, beta, delta, so A alpha, A beta, A delta, then C fibers, all these different types of nerve pathways that bring it up. When you cut your finger or have an injury, it's these A delta fibers that bring it up to the brain. So when those propagate up the nerve channel, let's say it's your finger, in our terms the back, it goes into the spinal cord, up the posterior part of the cord to the brain, where it goes into the thalamus initially, and then it diverts. And so you process that pain as it diverts into the different parts of your body. The somatosensory cortex is what then tells us, oh, that's painful, and then things start to happen. So you start to process that pain once it reaches the brain. But what if when that heals, but it takes a long time to heal? Let's say you get your finger, you get an infection. So that pain keeps going, you still have that inflammation. So then your brain's constantly processing that pain, and eventually it starts to become sensitized. So that finger can heal, but sometimes you can still feel the pain in that finger because your brain is still wound up processing that. So it's no longer a structural injury on your finger, but you still feel like something's wrong. So that's when you have to treat the nervous system. So it's the same thing with our back. You may have an initial injury, maybe getting out of bed or picking up your child hurts your back. Maybe you get a little inflammation. But then down the road, we see on the MRI, well, structurally it's okay. You can't see any inflammation on the MRI, meaning edema or fluid buildup, but your brain is still trying to tell you something's wrong, though everything's healed from an acute standpoint. So your brain is still working, it's still firing that, and that kind of comes back to that fear of pain. So if you're then, your brain is still telling you something's going on there, and then you develop that emotional response, which again, emotion doesn't mean it's made up. It means your brain, through that frontal cortex we talked about, is still processing all that.
So my pain is real.
Pain is 100% real.
Pain is real.
That's where it gets hard to treat because it's now treating the nervous system.
Because you mentioned sort of in the talk of it, a difference of acute and what would be chronic. The acute, the immediate injury, but that's also immediate damage.
Correct.
Where we could be talking about with the situation I described. Does pain mean damage? Does pain equal damage?
It can.
It
especially
can.
Initially or in an acute
So
setting.
definitely in like a trauma, like
Exactly.
a mechanical injury. Okay, so then what would it look like if I came to you and there was nothing on the images? What's really going on there if there's nothing that
structurally needs to be fixed?
Right.
So it's then how that nervous system is continuing that loop of telling you there's something there.
So the signal's off.
Exactly, 100%. That's a good way to put it. So we got to reset that signal. So let's say you have back pain. It goes up the spinal cord to the thalamus, and then it diverges. That's kind of the relay system. So it sends part of the signal to the brain, the somatosensory area of the brain, that tells us now you need to do something about it. So if it's acute injury, it may say stop moving, or it sends a signal down to try and dampen that pain. If it becomes more, so when it goes to the thalamus somatosensory cortex, tells you need to change your behavior because you have an acute injury.
So if it's an acute injury, it tells me to stop moving. Is that cortical inhibition where some of the muscles kind of, you don't want to say maybe stop firing, but they don't tend to work as well or respond as much, or is that an all-out spasm where
both?
Okay.
So it's going to tighten. It's going to send an inhibitory pathway down to try and dampen the pain signal. So the pain goes both ways. It goes up and down. So you get pain that goes up to the brain, but then when it sends a relay to this area called the PAG, periaductal gray area, that has nerves that send down to try and dampen that pain signal, so you're not hurt as much.
Okay.
So the brain tries to regulate your amount of pain in and of itself through your body's own endogenous opioid system, like endorphins or norepinephrine. So it tries to dampen it without taking a medication to do that. So that's what those medications do. They just try and enhance that dampening of the pain, but your body tries to do that in and of itself. So when the pain process comes up, the thalamus goes to the thalamus goes to the somatosensory cortex. It also sends it to more the emotional system, which we talked last episode, through the limbic system, and then the amygdala.
This is
the
how I
prefrontal
look
cortex.
at movements that scare me, even though they're not scary movements.
100%.
Because I've taken something that hurt me, and now all of a sudden I say, well, I bended, I lifted, I twisted. I can never bend, lift, and twist again. So bend, lift, and twist is what I think is the worst possible thing in the world.
And would you say that's where it starts to shift from the actual injury into now that's where the emotions start getting involved? Because your natural instinct is, oh, this hurt me. I'm staying away from it. I'm
100%.
Never doing that again.
Because when the pain pathway comes up, it goes once to structurally how can the body quiet down that pain, heal itself, but also to that emotional system with the amygdala and the prefrontal cortex, and that's where you start to get that memory of the pain and limit behavior, limit movement, and also have that fear.
At that point, would you say it's really, really important to seek help at that point?
I mean, that's where at the initial person you've seen, if they can explain this to patients, we'll have a lot less chronic pain.
So that's the first step in healing is education.
Exactly.
Okay. Because you need to know that how the mind works to actually be able to perceive it correctly.
Because just because you have an emotional component to pain or chronic pain that doesn't have a structural problem anymore, doesn't mean you don't have pain or have a problem going on. It's just more within how this nervous system, which is your spinal cord, the nerves, and the brain are functioning, versus a structural problem to go and fix with surgery.
Because I think right now you have two things happening. A person has pain, and they go see a physician. One of two things are normally being explained, and that is stop moving, don't do the thing that caused the pain, and let's see how it feels, or let's explore maybe a surgery.
Yeah.
So that's really like the two options. So when somebody stops moving, then that's where it in most cases sets off this cascade of even other events. Now we got more things that are at risk than just this situation that's going on.
Well, because if you don't
in the back,
for example, I've sent you guys a bunch of patients to train initially with a stress fracture in their low back. A lot of athletes, teenagers get this if they do a lot of gymnasts baseball players where they're doing a lot of extension, they get a little stress reaction in their vertebrae.
Overuse.
Exactly.
Yeah.
And so that can cause a stress reaction, edema, inflammation in part of their bone called the pars lenticularis. And if they keep doing through that inflammation, you can get a little stress fracture. But so initially, patients would always come into the doctor, they'd say, oh, you got a little stress reaction or a stress fracture, rest for 2 months, takes, quote unquote, 6 weeks for bone to heal. We're not going to do anything for 6 weeks. But instead, so that's just trying to treat the structure, but then the whole nervous system is being set aside. So that's when you develop the more chronic pain because you're not treating them in tandem. So you can still treat that stress reaction by avoiding movements that irritate it, but keeping them moving. So then the nervous system doesn't get wound up and they don't develop that fear avoidance.
So say that again in a different way. I get hurt, but I actually do have a thing. I have something going on.
Correct.
The worst thing to do is to stop moving because then I desensitize my central nervous system. I sensitize
become
my
more
central nervous
sensitive.
system.
It becomes wound up.
It becomes wound up because so this is, to put it in an athletic perspective, this is if I have an Olympic meet next week, all of a sudden I stop doing things that keep my nervous system challenged, and then I become sensitized to basically anything, and I get kind of hyper, I can't really rest, and I get weird in that nature.
Correct.
So in an athletic aspect, that's what that looks like.
Exactly.
But in an injury one, it takes the pain signal and ups it.
Elevates
Exactly.
it, yeah.
Okay.
So that pain signal is still there, and it may, if it's sensitized, you leave less of that initial movement to stimulate that nervous system. So if it's sensitized, initially you can do, if you're a normal person, never had pain, you can do all this stuff way up here and never reach that threshold in the brain for that pain signal to go off.
Okay.
But if it becomes sensitized, your threshold is now down here. So little movement, light touch, a little bend at the hip may then irritate that back because you've sensitized that nervous system. Because maybe you've treated that structural problem, for that example I just used, that little stress reaction in the back.
Yeah.
But you let go of that nervous system response and you let that keep propagating by not moving, by pulling back, by just resting and doing nothing. And so then that nervous system becomes wound up. So now the structural thing's gone, but your nervous system has lowered its threshold for firing that pain signal. So just little movements then set it off. So treating both in tandem is really going to be the best way to avoid this chronic pain, or if the chronic pain's there, to also treat it.
Taking away movement. So let's say the pain, let's just arbitrarily toss that out there, scale of 1 to 10, my pain is a 5. I want to avoid movements that take me well beyond a 5, but I want to continue movements that may keep me around that, but keep me moving.
Right.
Okay, so Dusty, then my next question is to you. So I come to you with that in mind. What might the first couple of workouts look like? Or maybe if we just said it this way, if you had an athlete who wasn't in pain, what would just a typical day look like, really broad, general, of a workout?
Typically, we're going to have some type of a strength component where we're looking to build strength in that session. And then, just from a functional standpoint, we're going to maybe implement in some other movements that are going to complement whatever the main lift. So let's say it was a squat.
Okay. Got it.
So after we did the main lift, and this day it was maybe a back squat that we did, then we maybe move into some complementary movements like lunges.
Okay.
Could be step ups. And then we may even do like posterior as well. So now we hit some, could be RDLs, hamstring curls, there's a lot of different things, but even glutes. So we work, say, glute bridges.
Okay.
So that's typically how it would work. And then there's going to be typically like an aerobic piece to it.
Okay, so some sort of conditioning that follows some sort of strength that may even have a bent towards an auxiliary. Again, this is really broad.
Yeah.
Maybe this would be maybe GPP. We're not
Absolutely.
talking about something that may be specific to a weightlifter or a power lifter or a marathon
What's
runner.
GPP?
General physical preparedness.
So more like for daily activity. Yeah. This is just like, hey, I'm trying to help make you the best human that I can.
And it would also be, and correct me if I'm wrong, a GPP would be fantastic to do for just about anybody forever and always, assuming, depending on what point of the season they may be in. So if I'm in season, maybe GPP isn't the best thing for me. But if I'm out of season, maybe the best thing for me is to do some sort of preparedness to get me ready for the training that's coming up.
Well, Exactly. I mean, I think GPP is really good, and I do that a lot. Implemented in it could be in breaks in the season, it could be off season, but it just helps to keep athletes healthy.
And it can be a break and fun.
Absolutely, yeah. Switching it up, just from maybe the monotonous of like the everyday training, and especially if you're training to do something very specific, that can get boring.
Very much so.
Because you're trying to be the best at one thing.
So now that's a great descriptor of what it would look like if I have no pain. So now I have pain.
Yeah.
And I come to you. What does the, again, broad general scope of a workout look like?
Well, I think for one, it's finding movements that aren't irritating.
So it starts with a little bit of an assessment. I come to you on the first day and you're going to say, move this way, move this way, move this way. And I'm going to check the boxes. Ooh, that's a red flag.
We're going to take a look at it all. It may be back pain, but we're going to take a look at what your overhead position looks like.
Okay. How would
we're going to take a look at your squat.
Explain that to me. What would looking at my overhead position, how would that equate to something that could be going on at my back?
Well, it's going to tell us a lot about like the thoracic and the upper back. So what's the mobility look like? If your overhead position, this is your overhead position, that tells me there's some opportunity for some mobility in just that upper back.
So limited shoulder flexion means that I probably kick my back or overextend while I'm doing something overhead.
And then that's going to open up the question of, hey, what do you do? What do you do for a job? And so I would say 9 times out of 10, that's going to be something at a desk. And, so then that kind of, you're starting to really build this picture of what your life looks like. That helps me as the coach understand, okay, this is what we're working with. If you're at a desk 8 hours a day and you're dealing with some low back pain, and I take a look at your overhead position and it's here, well, that tells me there's a lot of things that's going on up in this upper back that could potentially be causing what you're feeling in the low back. Again, I think probably one of the things that I hear the most often is somebody comes in for low back pain, but then we're doing like an overhead press. And that seems like, wait, my back's hurting. How is this helping my back? By doing those things, all of a sudden now my lower back pain is decreasing.
So that's what you were talking about, where we're going to do movements that don't hurt, that can desensitize the system, even if it doesn't look to a general population like, oh, why would I press to help my back?
Well, what you just said was, I don't want to say groundbreaking, but no one does that.
Yeah.
So typical physical therapy, the way our health care works is you come in for low back pain, you're looking and getting treated for the low back, which is asinine.
It gets super mechanistic.
Because it's just dumb.
Instead of all the other stuff.
We got to be holistic. Our whole body is connected. Our spine goes up from our head all the way to our feet. That fascial tissue and the muscle system, the nervous system all connect. So if you just treat the low back, but you're kyphotic, like you mentioned, bent over in the upper thoracic, just like you were mentioned, you have to arch back to get those shoulders back.
Which gets
you're never going to get that
extension
back
in the lumbar then. Our approach is always, we kind of look at it as a pillars.
Sure.
It's assessing joints. So we're looking at the ankles, we're looking at the knees, we're looking at the hips, we're looking at the shoulders, we're looking at the elbows.
But you went outside of that. You even said, we're doing all of that, but then you're like, hey man, tell me what you do when you leave here. Because even if you're doing a really good job in the gym, 100%. You're doing a whole bunch of other stuff outside of the gym.
At most, I may be with you 1 hour, and that could only be 2 times a week. Well, there's a lot of other time that you're spending outside of the gym, and if we've got poor movement patterns, then that could be contributing. I would say, honestly, in most cases, it is contributing to what's going on with their back pain. And it could be as simple as just changing from a seated working desk to a standing. And now all of a sudden, that position changes for us. So it's making those little adjustments all at the same time. Now we're implementing in these maybe new movement patterns that we haven't even been exposed to, or we're just cleaning up movement patterns. I think at one point I had mentioned it to you that there was a stat that I had read where like 98% of back pain goes misdiagnosed, should be diagnosed as movement dysfunction. So it really
100%.
comes down to how we're moving, and those repetitive things that we do.
That's what the MRI is not going to pick up. Your
And this
initial
is-
scenario where there's nothing wrong with the back, but if you don't look above and below the back, how the other joints are moving, then you're going to miss it.
But
you're
then
going to just say
also
everything's fine.
Talk about what's going on outside. And you actually, from all of the athletes that you send constantly, we've talked about that, and they say how well you do at actually getting history and actually spending time. But then you get another professional, a movement expert that gets history and then watches beyond what just you're telling them. So you're going to say, I want to see you squat, or I want to see you touch your toes, or I want to see how you get to the ground. And then from that position, you make adjustments in movement first, as opposed to, let's say, isolating a muscle.
100%.
Okay.
Yeah.
Okay.
Yeah. We're gonna. That's gonna be the very first thing we look at is how do you move.
So you're not going to go and just say, well, let's just work on this one piece, lower back or glute or hip flexor, but we're going to look at the whole system.
Which is why this model works versus a lot of physical therapists or other clinicians who just focus on, oh, it's your low back, oh, you're tender in the QL, we're going to work on this for 6 weeks.
So if I'm somebody
BS.
that's hearing this and watching this, and I went to somebody and they're like, oh, let me just massage on your QL.
Put a TENS unit here.
Yeah.
And put
Well,
you
if
some
the
ice.
focus, I would say, is all on that one area, that's a problem.
You got to run.
So
Yeah.
what? But if I went to you complaining of a non-specific lower back pain, and you were like, "Cool, we do this, this, and this, and then we're pressing, and then we're lunging," like, oh, that's a whole different thing. We're actually looking at making the body move the way through space as it should.
Yeah, I mean, we're not doing anything that your body isn't designed to do. Actually, and a lot of times we're just maybe introducing or reintroducing the things that everybody can do these things.
And
no matter age, no matter athletic experience, like you can do these things.
And you started with the assessment to see what was sparking me or emotionally,
I think that's,
for lack of a better term, triggering me.
sparking is probably
Okay.
the
So then
best.
I took those out.
Yeah.
And then I take the variety out, right? So I
Yep.
take some of the variety out. I move in a way that feels good. I may be doing things repetitively, but as I'm doing that, you're starting to work in hinging scares me. So you don't start with hinging. You
Yeah.
start with lunging, let's say, and then you work until I get that movement back. You don't just exterminate that movement.
No, and if hinging scares you, that is going to be. I'm working extremely hard to get you hinging.
Got it.
Because it's at the forefront, really, and it's blocking your road to recovery.
And then that's the thing that if I have to think about that in the daytime, that gets me weird. So if I never practice that, then I'm constantly
Go ahead.
I would say so let's say that it's fear of hinging that is aggravating you or causing issues. So what happens from there is now because you've decided I'm not doing this one thing, now you start doing all this other weird stuff. So
tell me what.
when you go to pick something up, typically
You'd bend over.
I would hinge at the hip, I would reach down, I would grab whatever the object was. But now all of a sudden, I start squatting, and maybe my squat's not very good, or I'm doing this weird lunge type thing, and I'm just being so protective.
But that's what everyone tells people to do. Don't bend at the waist, squat, or lunge to pick something up.
Yeah. And so
That's where that
How
bad
did we get to that place? Is
Fear.
that too big of a question? Is it fear?
I think it's all fear, and it's just easier to say, "Hey, don't do this," than it is to say, "Hey, do this." Try.
There was a study in the late 70s. I'm going to forget the author's name, but he was in Europe somewhere, and he did a study on specifically looking at back pain and discs. So looking at pressure in discs and what put more pressure on the posterior part of the disc if you had a little disc bulge, which we talked about. Everyone gets disc bulges, so we don't need to focus on that because it's basically normal. Everyone's going to have it. So
not a
that's how they
pathology.
started
Everybody
limiting
has it.
movement. If you lay on your back and put your legs up, that has the least amount of pressure on that disc. When you hinge at the weight, it's the most amount of pressure on the anterior part of the disc, pushing the disc backwards. So that's where that limiting hinging came from, to the best of my knowledge, from that study in the 70s.
From a single study
and it's
in the
just
70s.
propagated. So that's where continuing your education and adapting what you learn is so important in medicine, which we don't see a lot. is people practice one way in the 80s or 90s from that study, and then as we get more studies and now 2020s, people aren't changing the way they're treating people because they've been doing it so long. You got to adapt.
So primary healthcare, though, there's a shortage of people to be able to provide healthcare in a way such that you'd be able to actually talk to somebody about how they could pick something up, generally speaking. So in that aspect, if I was and I'm just trying to frame this in the right way. If I was to go to somebody and I said, "Man, I hurt my back deadlifting," would it be right for them to be like, "Well, stop deadlifting," because they assume that you're deadlifting wrong? But then a better statement would be, go to somebody who could teach you to do it right.
Yeah.
And explain why, because you got to hinge.
Because you got to hinge.
And I think when they say stop deadlifting, I think that's such a broad statement that that's where the confusion really comes in. I think it's one, a lack of education from the person that's saying that, because that you've literally like asked this person to alter every single thing that they do.
Yeah, don't pick anything up.
So it's really, I think that point, I would say if you hurt yourself deadlifting, let's take a look at your deadlifting form.
Goes back to the movement expert.
Yeah, let's look at that and see if there's opportunity, to improve that piece.
But in defense, again, of healthcare, it's unfortunate, but they may not have the time to be able to sit down and if you get somebody sitting in front of you that's screaming in pain, cool, let's just stop doing what you're doing right now, because first and foremost, we're trying to get them out of pain. Yeah,
and well, it's a disease management system. We're just trying to treat symptoms along the way, put out fires, especially primary care, because they should be making the most amount of money as physicians because they see the most amount of patients, they have to know the most amount of symptoms, and then delegate. But unfortunately, they don't. It goes to specialists because they're the ones that do the procedures that get paid the most. So the primary care is just trying to put out fires and put Band-Aids on things and send them to someone else to control it in many cases.
So a better message, though, would have been you might be doing that movement incorrectly, but it's not inherently a dangerous movement.
You gotta prevent instilling that fear.
Yeah.
So you got to still encourage them to move, but say, maybe we just got to get you with someone that can help you move correctly.
So for all of our listeners, we would say something like deadlifting is not an evil thing. We just want to deadlift correctly.
100%.
Then how would you start if I can't pick something up off of the ground? Where do I start if that's the thing that hurts me?
Well, first, I'm going to work to try to find a position. Where is the pain happening? So it may be just assessing your hinge.
Okay.
And because if in your mind, if a hinge is this,
a slouch,
or a bend, then we can clean that up pretty quickly.
Right.
Just through some tactile cues, of, hey, let's create some tension here, or let's activate this muscle group before we start to move.
And if you've never had a coach's eye on you, that could be gigantic.
Absolutely.
Yeah.
But it's also just finding, so if today this is as far as I can hinge before I really start to feel some pain, okay.
Okay, so the first thing you did to get us back to hinging is limit range of motion, maybe with like a rack pull.
Yep. Okay. And it could even be as simple as like I've got you against the wall and we're just kind of working our way out away from the wall. We're sending the hips back till we touch. And that each time we go out further, we're getting a little bit lower.
Less about loading, more about patterning.
Yep. And here's the thing. After we do that, I would tell you again in sessions where I've had this scenario going on, if I start the session, and this is the most range of motion that I have in a hip hinge.
Okay.
After we move for 20 to 30 minutes, I'm not encouraging you to go lower. I'm merely just saying, hey, let's hinge at the hip to that point where you start to feel the pain increase. Every single time, naturally what happens without me saying, hey, go lower, by the end of the session, now that person is hinging here, and they don't even realize it.
So they increase range of motion on their own because they become more comfortable with movement.
Exactly.
Okay.
And the benefit, we haven't even lifted a weight yet. We may be holding a broom, or a PVC pipe. Then I'll bring that to their attention. Say, wow, just in the last 30 minutes, your range of motion has increased 10 inches,
And this is without putting your hands on somebody or rubbing a specific muscle group.
Exactly.
We don't do any of that. We take the person and we actually have them move through space. So it's active, not passive.
And we've moved, and we've really just kind of explained to them, hey, this is how you can do this in a very, very safe way.
After education.
Well, what's cool about that too is that's moving what people can see, their muscles, their joints. And so that's easy for patients and clinicians to understand, is we got to improve their range of motion or build up their muscle mass to protect something. But what I also like to educate patients on is that's our way into the nervous system. Is what we talked about in the beginning is pain is how the nervous system is responding. Even if there's no structural damage, pain is still real because your brain is still perceiving that pain and it's propagating because it's wound up or sensitized. So how do we change that? Many times in healthcare, it's give them a medication. I said the body has its own opioid system that binds to its own opioid receptors through norepinephrine. But what if, so we can enhance that by giving an exogenous opioid that they take by mouth and get addicted to. And then we've seen what happens in this country when people get that, especially here in the Appalachian area, but everywhere. Or we can give them an SSRI to boost their serotonin or an SNRI to boost their norepinephrine, all trying to improve that emotional response or that chronic pain. But what if we do that naturally through movement, through the muscles to get to that nervous system to start to desensitize it?
So this is where like aerobic exercise releases endorphins, so I feel a little bit better. This is where movement makes me feel a little more confident. More confidence
slowly
adds
you're
to less
chipping
depression.
away on that prefrontal
The mood
cortex, the
changes.
amygdala.
The perception of movement. All of a sudden, I'm not somebody who demonizes the deadlift. I'm somebody who can deadlift. And that completely reworks that.
Well, the belief. I mean, now all of a sudden they believe.
So that's the second piece. After you have the education, you actually have to be the sort of person that believes that movement can do something. Okay. Okay.
Yeah.
Now, so tell me about the dreaded. Instead of necessarily somebody that hasn't been doing anything specific for training wise, and then they fall into pain. But maybe it's somebody who has been training, and then they get that dreaded tweak of their back. So it's, I feel that thing, and immediately I want to stop. It doesn't even really matter. I could have been back squatting. I could have been lunging, but we've seen it a million times. Right then and there, if I'm that person, what do I do? But I can still walk. I didn't lose bow or bladder. I have all the feeling in all of the places. We know it's not catastrophic.
Yeah.
So what do I do? And I say this just because we've seen this many times out of many athletes. And the first thing an athlete does is freak out.
Yeah.
I'm never going to come back. I'm never going to be able to do this. There's so many things we tell ourselves. What is the first thing I do?
I think that's the natural response is, you hurt yourself, and I don't have time to be hurt.
The world's ending.
Yeah, and I'm going to stop. I think that's the worst thing that you can do. Is stopping is the worst thing.
So I did. Let's just use our deadlift. I was pulling deadlift. I got really weird. It took me to my knees, but again, I don't lose bowel. I don't lose bladder. All of that stuff's fine. I still can feel my toes.
Yeah.
Okay, so I can walk. What do I do? Do I cease and desist that training session? Or do I try to preserve the session as best as I could? Maybe do I remove deadlifts? What do I do?
Yeah, I think that's the first thing. Is
So
if you're in the middle of a deadlift session and you're lifting some pretty decent weight, I would say that we're calling that for the day. But we're not stopping hinging. So we're going to go immediately right into a crisis management, type situation.
We were talking about signals. So the signal was, whatever it was to me was, Al, this hurt. Yeah. I send a signal back was fine. I'll shift movement patterns, pivot, but I keep moving.
Pivot. And we're going to go into a very controlled, movement pattern. So it could be that we go to the ground and we start with, just some leg raises, bridging. It could be cat-cow. So again, we're just reintroducing movement back as soon as we can.
The same session.
In this session.
Got it.
Yeah. and just trying to promote that blood flow back into those muscles.
And this goes to the emotional part where I want to lessen that, not necessarily the pain response. That's what I'm trying to do, but I'm also trying to lessen whatever my belief or my mood about pain is.
Yeah, and
that's where I get
with that
mind.
instance, it could have been a little worsening of a disc bulge or a little annular tear in the lining of the disc. It could have been irritated some arthritis in the facet joints or strained a muscle or ligament, but it's still the same treatment. It doesn't mean stop.
Often is the case, and I find, Dusty, you can correct me, I find that sort of thing rarely happens at the biggest loading that I can have. Let's say I deadlift 500. It doesn't usually happen at 500. It's like happens at 225 on the way up.
Yeah.
So that's probably not a stressing of the tissue to such a degree that there's a mechanical injury.
Usually not.
What is it that's happening there? Is that an inappropriate warm-up? Is that I didn't sleep right? Is that both of those?
I think
and more?
I think it's
I think there's a lot of different things that could play into that. I think sometimes too is on some of those build sets or lighter sets. It's just the intention and the focus is just not. I mean, if you're going for a PR, you're dialed in.
That's okay.
I mean, you are making sure everything is like on point. Where if you're at half of your PR weight, you're gripping and ripping. And so
I was playing on my phone 10 seconds before this set. I just threw it down and pulled.
And you're working off of 3 hours of sleep, Okay. So I think it's typically like a perfect storm moment where it all kind of came together. But what I was going to say too is like, if I've got somebody who's just tweaked their back in a session, my response is honestly going to be, hey, we're going to increase the movement. So if I might only see you 2 days a week, but now because of this, I'm going to see you tomorrow.
Okay, and off when I'm not with you, do you give me specific?
100%.
Okay, what would those things be? Would it be?
Again, it's going to be like, hey, tomorrow morning when you wake up, here's 3 different things that I want you to do. And it could be, again, I'm going to probably take them to a very controlled position, like lying down, and just starting them with just some movement.
So maybe glute bridge, maybe cat-cow. Like, what would be if I was the guy who just did that back tweak where I can still walk, I can still move, but it hurts enough where I'm scared of it.
Yeah, the bridging I think was a really like easy way to get the hip hinge going.
Not because it's special, because it's movement that I can do pain-free.
Yep, okay. and again, we're starting to just build on the confidence. If I can get one movement to feel good and pain-free, then I can increase that movement. So now we could come to a standing position, and it may even be again that we're just trying to work back to let's find that position that you have no pain in.
Okay.
And for today, that's what I want you to do. Maybe 2-3 times. I want you to take a break. I want you to go to the wall. I want you to do
unloaded hinges.
Yeah, this is just movement. Again, just for the blood flow. To loosen things up, and it could be walking. Hey,
how many times in a perfect world would you ask me to do that a day?
I would say depending on like how
much pain
pain you were in. If your pain is like really high, I mean, I could ask you to do that 2 to 3 times a day.
Okay.
Okay. And so the focus is going to be really is I'm going to work with you as much and as often as I need to in the next 24 to 48 hours to get progress so that we can swing the pendulum back toward like you seeing, oh, okay, like I'm feeling better. Mm-hmm. I'm going to keep, heading in this direction because I think, the worst thing that you can do is shut it down and lay on the sofa now for the next 48 hours.
And that's what you said was kind of the main, again, we're not attacking anybody, but you said the main recommendation is kind of like, we're going to stop everything for 6 weeks.
Let's let this settle down.
And you're saying that's
it's the opposite.
It doesn't mean you may not need something, a medication, an injection, or something else medically to help keep this progressing. But what Dusty's doing with them initially is keeping them movement. So you don't get that secondary muscle spasm or tightness or loss of movement so things get restricted. So you're eliminating that secondary factors that are just going to make this more chronic and harder to recover. Doesn't mean something may not have happened with that deadlift at 150 pounds that you can do 500. But we may need to treat that. But it doesn't mean if everything is okay and you're able to walk and move, it doesn't mean you can't keep moving and prevent that secondary confounding factors from coming on, and we'll deal with the root of the cause, if there is truly something, when you say
that's a really good point. So what it seems like we've come around full circle where Dusty, you would agree that we need to keep moving. Dusty, you would have them keep moving, but we're also not the sort of person who's, I'm never going to take medication. That's the worst thing. I don't know. It almost seems like today, and correct me if I'm wrong, that we almost think experts are sort of selling us something, and we want to avoid that. Or all medication is bad medication. And then it almost prevents it. But then on the flip side, it's all movement's bad movement because this movement hurt me. What it seems like we're saying is that if we put both of these together in a meaningful way, we'd get better a lot faster.
It just comes down to educating the patient, the physician, and teaching them that you don't need to be scared of me over here trying to do something for you medically to help you. I'll show you why that's helpful. You don't have to just blind trust me. I'll show you the evidence, but explain it to you on your MRI and things like that. But also, it doesn't mean avoid everything, so that we can meet in the middle. It's like society, healthcare is the same way. There's this division where it's all or nothing, where if you have the right education, you can realize there's a place in the middle for us to meet. And I think we're showing that.
Well, I think that's the important, aspect is, in a lot of cases, even when you do an injection, the intent is so they can move.
Right.
It's
not to cure them.
It's to get them, back to where we can get them moving again, because we just know that once we can get them back, once I can get you back in the gym and I can get you back moving, we're building back to getting you to where you want to be. Mm-hmm. The focus isn't on all right, man, we got to get back to that 500-pound deadlift. If that's where it happened on the road to that focus is not on getting back to like that heavy barbell. The focus is getting you back to where you're, again, moving with confidence, and you're able to do the things that your life calls for you to do on a daily basis. Mm-hmm. That's why we all do it. So it's amazing though to watch when somebody, I think we mentioned this on the last episode. We know it's coming. We know the setback is coming. We don't know when the setback is coming. But once we're able to work, we kind of, as coaches, we don't want people getting injured, but we always see that as a huge opportunity and a turning point. Because at that moment, they're about to really experience something that they've probably never experienced before in training. And they're going to figure out how quickly they can get themselves back after a setback. Whereas before, this was like years maybe. It may have knocked them out of the game for, 4 or 5 years. And now you've like compromised all these other areas of your life in that process. So watching people come back from that little tweak is maybe like the coolest thing, the most rewarding thing that we get to do is because they see the power of it, and then now that fear, it's not even there anymore, and
that allows them to cope with life moving forward. Because if that first setback, they then fall down that rabbit hole of sit and wait and let your nervous system heal on its own, or we can actively treat that nervous system like you're explaining. That's going to, their nervous system, their brain is going to remember that. And the next setback, they're going to say, well, this is what I do. And it's not going to fall back down to that memory of that fear, that avoidance.
Yep. You immediately go into a proactive approach.
So speed bumps are going to happen. If I'm not moving and I'm in pain, I should get moving and have somebody who's educated to help me with that. And if I am moving and I just did something that put me in pain, I need to keep moving in a state that doesn't cause more pain.
100%.
Gentlemen, thank you for your time.
Yep.
That was good. Good to see you guys.
Yeah, man.
Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.